from the Nelson Group as one of the best 4 abstracts. Be there.
Thanks, Jim. All right, so as we bring up our next panel, this will be moderated by Carolyn Dresler, who will be, again, setting the stage. She's the Associate Director of Medical and Health Sciences in the Office of Science at the FDA Center for Tobacco Products Office. She's a thoracic surgeon, a tobacco control expert, and a member of the IASLC Board of Directors. And she'll be, like I said, setting the stage, and then we'll be hearing about 2 presentations that will be at this meeting from Dr. Marliese Alexander, as well as Dr. Jean-Francois Morere. And I wanted to mention also that at our opening ceremony last night, we had a wonderful presentation by the Honorable Nicola Roxon, who talked about the efforts in Australia with the plain packaging and tobacco control, which are really quite astounding. With that, I'll turn it over to Carolyn.
Thank you. Let me make a disclaimer. I am not here in any way, shape, or form representing my the day job, which is working for the FDA. They are very, very strict on those ethics requirements. So anything that I say cannot be attributed to my regulatory role at the FDA for the Center for Tobacco Products. So I need that very clear. I am so excited for how IASLC has addressed tobacco control. It has a strong history in making a statement about tobacco and the importance of prevention so that kids are not starting and that people are quitting so that they are decreasing their incidence of lung cancer. And then, as you may have noticed from the title that Dr. Goldstraw said, it's tobacco control, which is prevention and cessation, but also smoking cessation, because there's increasing evidence of the tremendous importance of persistent smoking during a diagnosis of lung cancer. So it's critical for us as members of this association to address tobacco cessation in the patients who are still smoking at the time of their diagnosis. So very important to address that. Let me put it into some context that it's estimated that there's about 1.6 million new cases of lung cancer each year, and about 1.3 of them will die. So a very high mortality, as you heard in the last session. So it's critical if we want to do something about this disease. It's really important to prevent it. It is a preventable disease. So not 100% of cancers are due to smoking, but it depends where you are. As you just heard in China, there's variable reasons and etiologies, but it's estimated around the world that it's somewhere around 85% in men are related to smoking, and women it's a bit lower, somewhere between 70 and higher, depending again on the environment that you're in. The next thing is, and I think this was pertinent to the last presentation too, let's pick a country like China, where it depends which survey that you look at, but it's somewhere between 53 and 2/3 of men smoke in China. That's 288 million men smoke in China. It's estimated that somewhere between 10 and 15% of people who smoke will get lung cancer. Let's just do 10% because that's an easier one for me to do in my head. That's 28 million people. What country can afford to treat that? You know, so it's an amazing number for a developing economy, and we all know that China has a quite burgeoning economy. But then go to Russia. Average life expectancy is 58 years because of alcohol and tobacco. And it's there, 60% of the men smoke. It's about 30 million. So it's 3 million men getting it. So when you start adding up these numbers, they are astounding numbers. And my soapbox, as you can tell I'm fairly strong about this, is that if we don't do something about tobacco, then we are saying it's okay for that number of people to die from it. And it's so not okay. It's up to us to be addressing both tobacco control, prevention, kids start smoking, get them to quit, because if you quit, you'll significantly and fairly quickly decrease the number of people who get lung cancer, therefore they're not going to die from lung cancer. And then importantly for this organization, that if they're smoking, that we really need to work on helping them to stop smoking. So with that, I would like to turn it over to 2 presentations, that excellent presentations that we had in the last session. And Marliese Alexander, if you would like to start, please.
Thank you for the introduction. So my name's Marliese. I'm a pharmacist from Peter MacCallum Cancer Centre in Melbourne, and I'm going to present just some of the findings from a review of our multidisciplinary smoking cessation program. So some of these facts have come across in previous presentations, but just quickly, worldwide, tobacco smoking is the single most common cause of lung cancer. In Australia, lung cancer is attributed to about 90% of lung cancers in males and 65% of lung cancers in females. Our current smoking rate is about 20% of our adult population, and lung cancer itself is our fourth most commonly diagnosed cancer, and it's our most deadly cancer. There's good evidence to demonstrate the benefits of smoking cessation, particularly after a cancer diagnosis. So patients will have reduced rates of cancer recurrence, improved tolerability to cancer treatments, as well as improved survival. So I'm going to describe to you our study, which describes a tailored smoking cessation program in a cancer population and also smoking behaviours across our hospital population. By way of history, in 2005, Peter MacCallum Cancer Centre introduced its smoking cessation program. The program consists of counselling and behavioural techniques, which are delivered through a nurse-led clinic, and also the provision of free pharmaceutical supportive therapies. In 2007, we branded ourselves as a totally smoke-free environment, so patients, staff, visitors, anyone to the hospital or around the hospital is in a smoke-free environment. In 2009, colleagues of mine undertook an evaluation of quit rates within our program, and this was actually presented at the World Lung Conference a few years ago. At the same time, the hospital began collecting smoking data for all newly registered patients. So we would collect smoking status, magnitude, and other histories of smoking. In 2011, which is our 5th year after being a smoke-free environment, we've re-evaluated the smoking cessation program and also evaluated smoking behaviours across the hospital as a whole. And that's the information that I'll be presenting for you today. So how we did this was via retrospective review. We audited the hospital data sets to understand the smoking behaviours, and then we did a review of the smoking program over a 2-year period. So that was 2009 to 2011. To understand patient perceptions and quit rates, we did structured telephone interviews with a subset of patients who participated in the program. So it was a small cohort of 30 patients. In terms of key outcomes, I'm just going to run over some of the, more prevalent findings. Of all patients, around 50% reported having ever smoked and 12% of current smokers. Now, this 12% is quite a low rate. The Australian estimate is 20% in adult populations, so this was already an indication to us that there was a culture of low disclosure rates. Of the current smokers, we were able to recruit only 7% into our smoking cessation program, so our recruitment rate was quite low. And of those in the program, 43% had not disclosed their smoking status at hospital registration. So this reinforced our idea that, yes, there is a low level of disclosure among our patients. Every patient enrolled in the program received a counselling or interventional behaviour session with a smoking cessation nurse, and 80% utilised pharmacotherapy. As I mentioned before, pharmacotherapy is provided free of charge at a cost. It's a net annual cost to the hospital of just over $22,000, which in comparison to our hospital drug budget is a drop in the pond. I think it represents less than about 0.1% of our budget, so it's money well spent. In terms of our phone interviews, we reported a 66% success rate, so noting that it is a small patient cohort, but a third of those reported successful cessation, so that's 6 months or more of smoking cessation, and the other third reported reduced consumption. So I guess the data that came out of our review is that our evidence-based model is having successful outcomes. However, there are clear areas where we can improve our service. So our first priority is to improve disclosure rates. We want to increase our recruitment rates, and finally maintain successful outcome rates. And hopefully by investigating and removing barriers to accessing smoking cessation programs, we can have a bigger impact on a larger number of patients. And that brings me to the end. So thank you for listening today.
Our next speaker is And I lived in France for 2 years, so I'm pretty embarrassed with my French ability to pronounce Jean-Francois Morere. I did all right. Thank you very much.
Thank you. It's my privilege to present our study about lung cancer risk factors and commonly held beliefs and access among the most vulnerable in our society. Two major goals in our study. The first one is to reduce the inequities in cancer control, which is also the main goal of the French National Cancer Plan. The second one is to promote lung cancer prevention and lung cancer screening. As regards the methods, EDIFI-3 is a nationwide observational study conducted by phone interviews among a representative sample of more than 1,600 subjects aged between 40 and 75 years old. We used a validated questionnaire EPIS, to score the population and to examine the association between the underserved status and lung cancer risk factors, beliefs, and healthcare access. Here is the EPIS questionnaire based on 11 very simple questions, such as contact with social worker, health insurance full coverage, yes, no, living alone, yes, no, and also financial difficulties, yes, no, practicing sport, taking vacation, and so on. Based on this EPIS questionnaire and score, we observed that underserved subjects represent 33% of the concerned sample. Looking at the results, we can see on this slide that they have more risk of more cancer risk factors, sorry, and as you can see here, higher BMI, less practicing sport, and they are more often active smokers. If we have a closer look at the smoking habits, we can see that underserved subjects have a higher consumption of cigarettes, and also they smoke longer, 29 years versus 26 years for the served population. These lifestyle factors impact negatively on overall and cardiorespiratory health. As you can see on this slide, underserved subjects suffer more often from anxiety, respiratory diseases, cardiovascular disease, and hypertension. All these comorbidities are well known to impact negatively on the good management of lung cancer. When questioning this population, there emerges a significant increase in personal history of lung cancer, with 10% in the underserved group versus 1% in the served group. It's the exact inverse of what is observed in the same poll for prostate cancer. If we look at the healthcare access, our observation go against our preconceived ideas. On the left of the slide, you can see the average number of consultations with a GP during the last 12 months, and this average number is higher in the underserved group when compared to the normal served group. It's the same trend you can see on the right part of the slide for consultation with an oncologist in subjects with a personal history of cancer. And looking at their trust in screening efficiency, we can see that the underserved subjects are more optimistic than the served one. As you can see here, 85% of them think that lung cancer could be effectively and easily detected by screening. To conclude, I would like to give you two take-home messages. The first one is that we have to work on prevention and not on care access. since it doesn't discriminate. And the second message is that underserved subjects have a high level of trust in lung cancer screening, but their behavior put them at a higher risk of lung cancer due to their smoking habits. I thank you for your attention.
All right, and we're now open for questions to this panel.
Dr. Alexander, given that your study population were less than totally honest about their smoking at presentation, have you subjected your quit rate to an objective assessment?
No, we haven't. Our smoking cessation rates that we reported from our patient interviews were actually quite similar to those reported in the 2009 study at our institution, and that study was a prospective study with biochemical confirmation. So the fact that we produce similar results hints that our patients are telling the truth. But absolutely, in terms of non-disclosure, that's a key focus area, and I think part of that will be patient awareness, patient education, and that it's okay to tell us you're a smoker when you present to the hospital. And equally with that is the staff training and staff education of, so this is a relatively new implementation at our hospital to record this data at registration. So how those staff members go about bringing up the topic and asking those questions as well. And that's definitely an area where we'll be focusing in the future.
Dr. Morere, we know that the cost of cigarettes is a very sensitive issue in terms of patients quitting, and governments are careful to increase the cost slowly so that people do not quit in vast numbers too quickly. Your data would suggest that in this underprivileged group, they are spending a greater proportion of their limited income on tobacco, and therefore they might be even more influenced by rising costs of cigarettes. What has been the policy of the French government in terms of raising tobacco prices?
As you know, I am not part of my government, but I think the government has tended to increase the price of tobacco, but I'm not sure it's the good answer to this specific question, because for taxes and income to the government, it's a good idea, but we know that underserved subjects keep sufficient money to continue smoking, and they decrease other needs. It's very difficult only with the price of tobacco to push them to quit smoking. And there is also, I would say, a parallel market with less expensive cigarettes, not controlled cigarettes, coming from outside of the country.
Hi, it's Glenda from the Lung Foundation. I just wanted to ask, looking at prevention and increasing tobacco taxes and keeping the costs high, do you ever see a day where we don't have tobacco in our environment?
Sorry, I didn't catch it.
Do you see a day in the world where we don't have tobacco anymore?
I think I will not see this this day, but maybe in the next future.
I would like to address that because you may have heard of end games. So end game, END, I'm sorry about my voice. Different countries are looking at end games for tobacco. And one, for example, that's in Singapore, is looking at no tobacco sales to anyone born after the year 2000. So right now they're 13 years old. It's not legal for them to buy it anyway. But as they get older, that would gradually edge it out. Other countries have been looking at different quote-unquote end games. But I think that's fair to say, and I'm looking at the average age in this room, unfortunately, in our lifetimes, there will probably be enough tobacco consumed, and lung cancer to keep everyone busy, unfortunately. But that should not stop us from trying to slow that down.
I will ask the expert panel, should we be concerned about electronic cigarettes in the future?
That is such a hot topic, and I'm actually glad that you asked that. And maybe next lung cancer session we'll have a session on it. Is everyone familiar with the electronic nicotine delivery systems for e-cigarettes? In Australia, for example, they're illegal if they contain nicotine. In the U.S., they are growing at multiple, at a very steep incline. It's more than double digit that it's increasing, particularly in youth. I had, in our last session, we had someone from Stanford University, an oncologist, say, is it okay for patients to quit smoking with electronic cigarettes? Because that's what the industry wants you to think, is that it's a good way to quit. Let me tell you, there is no evidence to show that there are effective ways to help people to stop smoking. There is a study that does have some support from an electronic cigarette company that has demonstrated that it's about equivalent to the nicotine patch of somewhere around 10% quit. The problem that we're seeing is getting kids to start using electronic cigarettes, getting them therefore addicted to the nicotine, and then also what to me is so fascinating is dual use, so that they may be using their electronic cigarettes where you can't smoke because of secondhand smoke laws, and they're really pushing that quite strongly, that it doesn't have secondhand smoke, it's vapor. Studies have shown in that vapor are some bad chemicals too. But more importantly is that it's dual use of cigarettes. And what we know for lung cancer is that it's the duration of use rather than the number of cigarettes per day that increase your risk. So it's the duration of use. So if you're not quitting smoking, and even though you've cut down to 5 cigarettes per day, your risk is still going to be substantial for lung cancer.
Thank you. And with that, we're going to move on then to the next panel. But thank you very much. That was a great discussion.
Thank you, guys.